You have received a call from A&E regarding a patient who is diabetic and use glucose monitoring and has to do finger stick testing for blood glucose. He presented with a throbbing pain in the right middle fingertip from the past 24 hours. The examination reveals the affected finger on the volar aspect of the tip to be swollen, hard, and erythematous. The distal phalanx was extremely tender and somewhat fluctuant, but there was no pain in the distal interphalangeal joint and more proximal finger. The dorsum of the phalanx, including the nail and periungual areas, appear normal. A radiograph was obtained and demonstrated no abnormal findings. A differential in this situation differential diagnosis can be cellulitis, flexor tenosynovitis, herpetic whitlow, or metastatic tumor. The diagnosis is Felon of the middle finger. A Felon is a bacterial infection of the distal pulse base of the finger or thumb. As first described by the Cannibal, the anatomy of the distal phalanx is unique, with the volar pulse space in a confined sac and fibrous septa connecting the subcutaneous layer to the bone. An abscess in this region can lead to tensioning of the fibrous strands, increased pressure within the pulse space, and essentially compartmental syndrome with neurovascular compromise. In this way, Felon is distinguished from a simple superficial cellulitis which may precede it. Patients with Felon present with a swollen, hard, fluctuant, and erythematous fingertip, typically complaining of throbbing pain so severe that it has kept him awakened at night. There is somewhat a history of penetrating trauma to the fingertip, which can serve as an inoculating agent, although it may be forgotten by the patient. It is possible to have organism entering in the retrograde fashion via eccrine or sebaceous glands in the finger pad. Diabetic and immunocompromised are high risk. Skin flora comprise of the organism commonly seen in Felons, and most often it's Staph aureus or any other gram-positive organism. One of the differential can be suppurative flexor tenosynovitis, which can be clinically distinguished as typically involves most of the digit and certainly more proximal areas than just the distal phalanx. Flexor tenosynovitis also has characteristic pain elicited by passive motion of the DIP joint. Although quite rare, there are several reports of cases of metastasis of tumors of the distal finger, which at first presentation can be misdiagnosed as Felon. A Felon does not show any radiographic changes, although it's nonetheless recommended to rule out any bony pathology like tumor or osteomyelitis. It is also important to distinguish herpes infection of the fingertip from bacterial Felons. Herpetic whitlow is a self-limiting viral infection caused by herpes simplex virus. It is transmitted to the skin-to-skin contact and is often seen in medical and dental personnel as well as children's. The course of presentation of herpes lesion is much longer than just a Felon, which is typically quite acute. Herpetic whitlow may present with swelling and erythema, but typically displays fluid-filled vesicles as well. The diagnosis is usually made clinically, although it is possible to confirm it by use of zinc preparation or viral culture. It is important to distinguish herpetic whitlow from bacterial infection, as a surgical incision for the former can lead to complications, involve the entire digit or systemic spread, and is highly contraindicated. Infection of the pad of the finger can be managed non-operatively if the superficial cellulitis is typically in this case less than 48 hours and has not spread. In such instances, elevation, warm soak, and course of oral antibiotics, typically diclofenac or a first generation cephalosporin to cover gram-positive and skin flora is enough. In case of immunocompromise, additional gram-negative coverage is essential. Surgical incision is indicated as soon as the patient pain and physical examination indicates increased pressure in the pulse space, despite the absence of fluctuant abscess. Felon requires surgical drainage, both to clear the infection, relieve the intra-articular compartment pressure rise, and prevent neurological compromise. Most of these procedures can be done under local anesthesia and under tourniquet control. Our recommendation is to have local anesthesia with 1:200,000 adrenaline along with 1 ml of soda bicarb. There is a little disagreement over when the surgical management is indicated. However, there is controversy over the most appropriate surgical approach for routine incision and drainage of Felons. One goal, which is similar to all the techniques, is adequate drain in the abscess while minimizing damage to the neurovascular structures and scar formation in the area. Most surgeons use unilateral longitudinal approach, where an incision is made on the unopposing lateral side of the digit, ulnar for the fingers and radial for the thumb, beginning just dorsal to and 5 mm distal to the distal interphalangeal joint flexor crease, and continue laterally to the nail edge to a point just distal to the unattached portion of the nail. The incision is deepened by blunt dissection with a hemostat and similar instrument until the abscess is adequately drained and septations are opened. Extreme care must be taken as not to dissect proximal dissection to reduce the likelihood of piercing the flexor sheath and causing iatrogenic tenosynovitis. An alternative approach suggested by Kilgore is longitudinal volar incision. It is noted that the scar formation is minimal and that there is actually more likelihood of neurovascular damage when the lateral approach is used. Most authors, by the way, prefer the lateral approach, citing concern about scar formation over the most important tactile region of the fingertip. Volar incisions are typically used only when the abscess is small and localized at the volar pad and when a sinus tract already exists. The longitudinal volar incision is made in the midline, extending to the tip of the pad to within several millimeters of the DIP joint flexor crease proximally. It is important not to cross the flexor crease as subsequent scar formation can cause flexion contracture. Another third alternative volar incision can be made transversely over the point where the abscess has been localized. When the abscess is entered, intraoperative culture should be obtained for definitive identification and susceptibility testing of the involved organism. After adequate drainage is achieved, the wound is irrigated and packed with sterile gauze and non-adherent dressing. A digit is splinted and elevated for 48 hours and subsequently daily warm soaks are applied and active range of motion exercise are performed at dress change. At 10 to 14 days of course of antibiotics is typically begun postoperatively. However, the regimen should be changed once a clear focus coverage is identified at culture. Regarding the complications, a delay in Felon treatment can cause severe complications. This includes formation of sinus tract in addition to spread of infection in either direction, leading to osteomyelitis, flexitarian synovitis, septic arthritis of the DIP joint, as well as paronychia of the dorsum of the finger. Proper recognition of Felon is essential, as a complication of untreated Felon can be severe enough to lead to amputation of the digit.